We are stopping the share screen.
Tauche Mesami, hello and welcome everyone to our World Health Day, Our Minds, Our Rights event for Indigenous Women's Health Talk. And once again, we are really excited and so pleased to have Dr. Alexa Lesfrance here with us today. Before we start, I just wanted to let everybody know that before today's event, my coworker Samir and I went outside and we put some tobacco down just to ensure that we can start today's event off in a good way. Also, before I hand the mic over to Dr. Alexa, I just wanted to let everybody know that they may have noticed, if you're new to our Indigenous Women's Health Talks, that you're able to see Dr. Lesfrance or any of the co-hosts, but you won't be able to see any of the other participants who are tuning in, that you may even have noticed you weren't able to unmute your microphone. And I wanted to just address that and let everybody know that ensuring that we all who are attending today can join in and that we can make this as safe a space as possible. For that reason, that's why our cameras and all microphones are muted. And that being said, I also wanted to invite everybody to ask as many questions as you would like to Dr. Alexa. We have the option within the chat box to receive and to read any even comments that you'd like us to share. Now, there will be within the chat box the option to choose who you send your message to. We just wanted to ask you, please not to choose Dr. Alexa, because she's doing the presentation. So that she won't be checking in on the chat box, but there'll be a few other names there, myself, Carly, as well as CJ. And if you would like to direct message us with those questions, we will collect them all. And I promise you that we will show them all to Dr. Lesfrance, either around the break time or whenever you request. Yeah. So one last thing is there will be a survey as we usually have. The link will be posted later on in today's event. And we also have for today's session a gift for everybody who takes that time to provide us with that feedback and that information and just to share any perspective that they wanted to. And so any surveys that are received by us, we will be mailing out everybody a small gift as a thank you for attending and for filling out and taking that time for that survey. So I would love to pass the mic on to you. Thank you everybody again for joining us and enjoy.
Perfect. Okay, so Carly had already mentioned that she had put out the SEMA for us. Normally we have an elder or someone more spiritual than I do an opening for us, but I figured that we would still start off with a smudge. And hopefully people can feel that through the screen, smell the sage and how it's cleansing us. Awesome. I'm gonna pass it around the room just for people to do it at your own leisure, but I think there's something so grounding about starting off with our medicines. I feel like it always centers me, and I'm really thankful. The medicines, Carly had told me that the community members here actually at the organization at Onwa, Ontario Native Women's Association, had collected and harvested it. So I think that's so beautiful that our own people were collecting and connecting with our own medicines. So I'm gonna start my slides. Perfect. We're good. So Today's talk, a little bit vague on the title. We're gonna cover a few things. But today is World Health Day. So this is actually a day that happens every year. The World Health Organization sort of has this day, and it's to honor, it's been different subjects throughout the year, but it's essentially thinking about what is impacting the world's health today. And they usually sort of do some like advertising, and they do just some promo stuff about what can we do as people living on this planet. How can we keep ourselves, our communities, and therefore the world healthy? So today's talk is about our minds. So it's titled Our Minds, Our Rights. So mostly what I'm going to be talking about today is the type of care that we as Indigenous people should be accessing and how to access it, and what your rights are. I think that's especially important when we're navigating healthcare systems that weren't designed for us, that we have that harm reduction, that we know, like we have this in our back pocket. And so these are sort of just my reflections and what I think would be helpful. So Buju, Masabekwe, Nishnakaz, Mkwando Dam, Regional Zaging and Nishnabek, Notmingwaning, Ndonji, Nishnabekwe and Dao. So like I said, my name is Alexa. My spirit name is Masabekwe. It translates to Sasquatch woman. From the Bear Clan, as are most medicine people. Lots of people in my family are from the Bear Clan. I originally actually came into medicine, so I'm a family doctor. I practice, I do locum work, so that means that when like other doctors are needing breaks, I sort of cover for them. That's a pretty common thing when people are in their first few years of practice. So I'm in my second year of practice, and I'm an Anishinaabe family physician. I did my medical school training here in Thunder Bay at the Northern Ontario School of Medicine, and then my residency program in Vancouver with the Indigenous Family Medicine Residency Program, which I can't speak highly enough about. Like for me, I experienced a lot of great mentorship from Indigenous physicians, and I think truly that's actually what allowed me to be the provider that I am today, is having that mentorship, because there's not a lot of people in medicine. Often we're not reflected in the care providers that we see, and so that's something that needs to change. So it's important for me to be able to learn and walk in both worlds. So I am a Western trained doctor. I have an MD at the end of my name. I'm also trying to learn about our traditional medicine. So I'm not as knowledgeable to the degree that I would like to be, but I trained with family and with elders just about identifying and harvesting. I'm not a traditional medicine person, but I have a lot of awareness and knowledge about things that people could have access to, because I think what we should be receiving is when we show up to a healthcare provider and they're our own people. We know the option, right? Today, am I gonna be giving you some Ramapril for your high blood pressure, or are we gonna do a medicine in a tea and talk about lifestyle? Like I think both of those things should be available regardless of what you practice. One to me is not better than the other. They both exist together, and I think it's the melding of those two that's where the sweet spot is. So we're hoping that as time moves on, we have more Indigenous physicians like myself, Indigenous nurses, PSWs, all the people in healthcare, because it makes a huge difference. So just to start off to talk about rights, because there's kind of the rights, like, I don't know, Bill C-53, or there's UNDRIP, which is an international law. So there's a lot of legal talk about what rights are. And before we even get into that, I think it's helpful to really clear up that we as Indigenous people have inherent rights that were given to us by Creator. So a treaty didn't give it to us. An agreement that we signed, these are just so inherent, means that they were already yours. You were born with them. Those were yours to begin with. And so we have rights as Anishinaabe people, which are completely different than treaty rights, different than rights that happened on the United Nations level. And so I want to talk about what those rights are, because a lot of it is related to the health of our planet. So we have the right to live Minobomatsuen. We have the right to live a good life, and to live in a good way, to live a good life, we have to be in relation with one another. And so there's a saying, or a sort of like a greeting, an acknowledgement, a phrase in Anishinaabe culture, is all my relations. You know, sometimes you hear people say that and you're like, what does that mean? All my relations. I don't mean my cousins down the street or my mom or my grandma. I mean, I am talking about them too, but it's all my relations is essentially it's a traditional legal principle that in sacred law that all things in the universe are gifts from Creator, have meaning and purpose, and they're connected. So I am on the same level. I have the same amount to right. I have the same amount of right to life, right to healthy food options, right to healthy environments, as much as insects, birds, fish, four-legged, two-legged, all of the elements, Mother Earth, land bases, because all of those things are animate. So even in our language, you can sometimes, you can see how like a drum or a pipe, like how, like whether something's inanimate or animate, alive, and so those things are alive. And so I think it's always humbling, something that I always use, something I do to humble myself, because it's something that was told to me was, someone was like, look at that, and there was like, look at that rock on the ground. I was like, oh yeah, like that's a nice rock. She's like, you're no better than that rock. I was like, oh, okay. I don't even know what we were talking about, but it's just like out of nowhere, she's like, that rock has been here longer than you. I was like, right. And when you think of it like that, that's so humbling, that a piece of sand on a beach has been on this earth, on this plane, longer than you have. And so that's why when we have rights to our health, I'm talking about the health of us as individuals, but also what's happening on our earth. And we have the right to self-determination. Self-determination, essentially what that means is the right to choose. You have the right to govern yourselves. So in all forms of government, we have, and how governments work, like how our government works, they have control of land, water, minerals, timber, wildlife, roads being paved, all of these things. And so I think in order for Canada to move towards truth and reconciliation, it starts with self-determination. And that's true of health, that's true of land, because we know what we need for our health, and there are systems within Canada that deliberately block those things. And so we need our own systems of governance and to be able to self-determine our way of living, our way of life. That's really, really important. Because we never actually ceded our inherent jurisdiction surrounding lawmaking. Like, we never signed the thing, like at the treaty. Like, for example, we're on the Robinson Superior Treaty. I'm from Beach-and-Wabaga, Anishinaabe, or Rocky Bay. That's a part of the Robinson Superior Treaty. There's two versions of it. There was some signing about like, okay, access to this much land, this much water, but we never actually said, okay, now you have the right, Canada, to make laws that impact and apply to us, and our traditional practices and customs. So we actually, we haven't given that up. And so it's a really difficult thing to live in a world where Western-based colonial systems of justice have been imposed on our nations, right? Like things, the way that we govern, that's not how we would normally, but it's what we have access to. And I think a big part of that is that it's just, there's a really big focus on the individual. There's about inherent jurisdiction regarding law making for our nations, and they don't necessarily respect the spirit and intent of our Anishinaabe laws and our structures. And for some people, like in our area, it would be like clans and what roles you would have in the community based off of that. So there's a lot that I think is helpful to remember, that when you physically show up in a doctor's office, in the hospital, in the emergency department, places where you're likely going to encounter a healthcare provider, like this is our land. And we have inherent rights that were given to us and there's no like coming in between that. We have, that's our right, and that's what we need access to. Something that I think is important, especially when we're talking about little kids, abenoji, our babies, our just our children that are growing up, because we also have these rights, but so do they. And I think a lot of what we do in healthcare, in anything, we're always thinking about the generations that are behind us. How are we taking care of things so that when our young ones grow older, the legacy that we're leaving behind is something that they can be proud of. And so there's the right to identify, so to know who they are within the context of where they live. There's the right to know, learn, and speak their language, the right to traditional healing that reinforces identity and culture. Like I said, the right to a good life, which is Minobamatsuin, the right to land for the future, the child's future lies in the land, the right to lifestyle, to their spiritual name. Every single person, and every single Anishinaabe person has a spirit name, or a traditional name, or a name that was given to you by Creator. And so it actually exists right now. Like, even if you're like, oh, I don't know what it is, that's okay, but it exists. It already existed as soon as you came into this plane, as soon as you came from the spirit world to this 3D dimensional world on Earth. So, and that's the thing, when people are getting their traditional names, which I think is a big part of like treatment options for depression, anxiety, ADHD, that's actually, honestly, I think a really important treatment option. Because it's hard to know where you're going, what you're doing. It's hard to feel grounded in your emotions when you don't know who you are, and your name connects you to who you are. So it exists. It's already out there. Someone who's well versed in ceremony just needs to be able to, drum, sing, smoke a pipe, and be given that information. Because you have to understand that when you're being given your name or your clan, like, the person right then and there isn't making it up. It was already, it already existed. It's just, someone with some different spiritual gifts is accessing it for you. And I think truly, at least for myself and for a lot of my patients, I really have noticed that there's a huge change in people's health and mental wellness when they know what their name is and they can say it proudly. And to know where your clan is from, to be protected both inside and outside of family, to have a life's purpose, right? Like, to not, and just even the right to be joyful and happy. Our well-being is, and a lot of people know this, our well-being is intimately connected to the rights to clean drinking water, food sovereignty, and security. There's so much illness that I treat where the underlying cause was one of three of these things. For example, diabetes is fully linked to food sovereignty and security. If you do not have, first of all, if you don't have land to access to hunt your traditional foods and traditional game, that's something that keeps diabetes under control. If you do not have the funds to go to a grocery store, diabetes gets worse. So there's so many, even like drinking water, or just clean water. So many people, people have a lot of eczema and asthma, and a lot of that is from pollution and in the air, and a lot of skin conditions, a lot of the root causes, because they're autoimmune. Autoimmune means your body thinks there's something going on inside. It thinks there's something wrong. So it's going to try and attack those things. And so there's a lot of autoimmune conditions. I truly think these are some of the root causes. And that's why I don't think we are well as a nation, because our earth is unwell. Our plant relatives are unwell. Our animal relations are unwell. And so our spirit relations are unwell. And we as Anishinaabe people, it's hard to live Minobamatsuin when those four ways of healing aren't, the emotional, spiritual, physical, mental, if those things aren't connected and being treated wholly. So this is I think the promo, the year's topic. Like I said, the World Health Organization it's pretty much like the health of millions is increasingly becoming under threat. Disease and disasters loom large. There's disasters which are often a result of, like mining, land theft, all of these things, global warming, right? Like, which is a result of excess waste. These diseases are causing burdens, which cause death and decrease to your ability. So this year's theme, My Health, My Right, was chosen to champion the right of everyone, everywhere, to have access to quality health services, education, information, as well as safe, clean drinking water, clean air, good nutrition, quality housing, decent working and environmental conditions, and freedom from discrimination. I don't know if there's anyone on this call who can say that they have all of those things. Truly, like I'm like, oh, okay, well, technically, when I lived on reserve, no, I did not have clean drinking water. We live in Thunder Bay. We are right beside a mill. I am not free from discrimination. So a lot of my journey within healthcare was very difficult, and becoming a doctor was very difficult. I didn't enjoy it, and it hurt me in more ways than one. But just because I'm a doctor, I'm actually not free from discrimination as an Indigenous person, because I can't hide that part of myself. So My Health, My Right, we need to champion the rights of everyone in all of our relations. Something that I want to talk about, because I'm really thankful for what our ancestors had the foresight to do, is, treaty rights are what we have, and that's essentially our relation to, like, pretty much what the crown is supposed to do for us, what we gave in exchange for. So there actually is, most treaties have a right to health because there's a sacred obligation. And in particular, I wanted to talk about a treaty based in the prairies. So treaty number 1, they actually came up with a medicine chest clause. So when European people were coming to the country and colonizing, our ancestors recognized that new diseases were going to be coming. New diseases that we didn't necessarily have medicines for, right? Because they're new. Like, the things that we have to treat are for things that currently exist. And so with the influx of new people, and even, biological warfare, smallpox blankets, all of this stuff, new disease was introduced. And so our community members were like, we need protection from this. They actually wrote that in their clause. It's called the medicine chest clause, which is and I think it was actually literally a box. It had like insulin, and I don't know, there were like some medicines in it, but it was to combat new disease that was going to occur. And I think that's important because it relates to something I want to mention, something that our clinics and what we're seeing in healthcare is starting to become a pretty big issue, right? Because our ancestors, vaccines are actually a part of that clause, the medicine chest clause, being able to protect ourselves from new diseases. Like, when that treaty was made, that was a part of it, vaccines. This talk isn't necessarily focused on vaccines, but I even think of it in a world context. Most vaccines aren't free in other countries outside of Canada. So even just the ability to have access to that and not have to pay for it that's already a big difference in terms of what's available throughout the world. So I want to talk about measles because there are outbreaks that are happening. And it's so infectious. It's so infectious. I'm like, oh, it sucks. It's so often when people get measles, so this is like a picture and it has a rash, and this is like a pretty pathognomonic rash of what it looks like. And then there's like some white spots in your mouth. But people, usually how they present, fever, cough, runny nose, red eyes, and this rash. And the scary thing is that it's spread through the air and by contact with breathing from your nose or your mouth. So if I'm talking to the people in this room, or I'm laughing, or I did a little bit of a cough, the virus will actually stay within the air for up to 2 hours. So like if another group of people came right after us, like think of that in classrooms. like all your kindergarten kids like being all super germy and touching everything, and then another group comes, right? It actually, because it's airborne. So when you think you have measles, there's something called airborne precautions, which is really shouldn't be in the same room if you aren't vaccinated against this. So I mean, some of the complications, I'm not trying to like scare tactic people into getting these things, but I think it's helpful to know that people can have really serious complications, especially babies. Babies that get measles, that used to be a death sentence a long time ago. And you can't actually get this vaccine until you're a year old. So, because it's a live vaccine. So children don't have immunity unless their mom had immunity and they got vaccinated before their pregnancy. So complications, I mean, you could get a pneumonia, which is a lung infection, and at its worst, you can get brain swelling. It's called encephalitis. It's where your brain swells. 90% of people who aren't immune, so say like there's a bunch of people in the room and they're not vaccinated, 90% of people who aren't immune, you have it, you're infected. And you spread the virus before you even have symptoms. So when you think of it like that, you're like, well, how am I ever gonna know if I have it? Those symptoms are so common. Like apparently I can give it when we don't have it. That's exactly why you need to be vaccinated, because of those reasons, because it's so it's a great virus. It's a very effective virus. It really knows how to affect us as humans. And rates are rising because we're not vaccinating. We actually eliminated measles in Canada 1998. No one in the country in Canada 1998 was fully gone. We didn't have it. And that was because of people's dedication to being vaccinated, and or they became infected, didn't die from it, and then they developed immunity. So you were one of those two options. Some complications, because it sounds like a lung thing because you're like if you're breathing and coughing and it's airborne, but it can cause ear infections. A lot of people get diarrhea. Some of those ear infections can turn into hearing loss. 1 to 6 out of every 100 patients suffer from pneumonia, which is like a pretty high number for 100 people. And it was, so this was like an old graphic, it was one of the most common deaths, measles in young children back in the day. But we're moving towards that, and we want to stop the movement towards that. This is what I'm talking about, the 1 in every 1,000, the encephalitis, which is swelling of the brain. And you have a cranium, right? Like this is hard rock. So your brain is soft. When your brain swells and it's pushed up against something hard, your literal skull bone, there's nowhere else for it to go other than to slip out the back, right? And so parts of the brain start to get compressed. And so that's when children can become deaf or have mental disability, or right, because you're pushing up against the parts that start to die off because your brain is so swollen, there's nowhere else for it to go. Same with like eye disorders. This can really affect your cornea, which is the outside part of your eyeball. It can lead to blindness. And truly, when I think of children, little babies with measles under the age of 12, it's truly a terrifying, these are very sick children that are in the NICU. They're getting IV antibiotics. They have IV fluids going, like they're just very unwell. And technically you can still get fatal brain complications several years. So like you're done with the measles, you survived. If you hadn't been vaccinated, like it reactivates, right? Viruses don't have cures. Some of them have treatments and some of them have prevention, but virus means that there isn't a cure. So you can prevent measles with 2 doses of measles vaccine. It's nearly 100% effective for preventing measles. And so that's why it's just such a low hanging fruit for a disease that has so much burden, like to our healthcare system, to everyone, right? If 1 in 20 people if one person could infect 20 people, if this became like a thing where everyone was getting it, like no one would be going to school or work because everyone would have measles. It's self-limiting for people who don't get complications, meaning eventually like you'll just like you'll eventually get over it, usually like after a couple weeks. But the vaccine, what it's called is MMR, and it actually at Onwa, I think we're working on trying to get the MMR vaccine. Is that right, Carly?
Yes.
Okay.
I think it's getting set up and, but I'm not sure about the arrival of the vaccine.
Yeah, Yeah, cause so we had ordered them and they're available at pretty well any clinic, walk-in clinic, public health, but we at Onwa are also gonna be getting the vaccines to get people vaccinated. So you're like, okay, well, was I vaccinated? I don't know, maybe. So how you know is if you were born before 1970, that there's pretty much you're just considered immune, like because there was such a mass outbreak, it was assumed that everyone was infected. Like, can you imagine all, like, however many millions of people in Canada, in the 70s? Like, I'm just like, oh gosh. Like, before 1970, you were just, like, screwed. So, yeah, you're probably immune. But if you did want to know, you would contact public health to get your immunization records, which I'm gonna talk about next. But the vaccine is a live virus, so that means that after you get an injection, because vaccines are either live or they're not. So after the vaccine, you know, you essentially are gonna develop symptoms because it's like we're starting a bit of a reaction to it early so that you can develop the antibodies for when the infection, if it were to ever come. Hence why child in the clinic with me has measles. I don't need to be airborne precaution, like I will anyways, like I'll put on a mask and stuff, but I don't need to be because I have my vaccines against measles. So it's really important. The schedule for, and who this really applies to is like kids under the age of 10, or if you've never vaccinated before. Because at 1 year, like just depending on the province you're in, we're in Ontario, you might be in BC, wherever. But the schedule at 1 year is you get your first dose of MMR, which is measles, mumps, rubella. And then before you go to school, like your kindergarten shots or like your school shots is what they're called, around age 4 to 6, that's our vaccine schedule. You get it when you're 1 year old. And then before you're around other journey children, pretty much, that's when you get your second dose. And once you have those 2 doses, almost 100% effective. Like that's it, you're done. You don't have to do it again. There are certain people who shouldn't get vaccines, or where it's not recommended, or you'd really have to talk to someone like and have a really in-depth discussion. So one is people who are pregnant. That's true of any live vaccine. Like you should kind of avoid that. People who are pregnant, infants under the age of 6 months, but ages 6 to 11, technically, if you were traveling somewhere that had measles, you'd be able to do one, but it would be kind of a bit riskier. And people with weakened immune systems. So, because ideally you would have wanted to do this early on in your life so that you weren't someone with a weakened immune system. And everyone else relies on others to be vaccinated, so that the virus won't spread to them. So that's a strategy, community immunity it's called, or herd immunity. So because a baby less than 6 months old and you're holding them and kissing their face, you know, they are not immune to measles. And so if you are vaccinated, then you're sort of helping prevent, you're creating this bubble or this circle around so that kids aren't being infected, because that's who it's most dangerous to, and older people. If you don't know, if you've had your 2 doses of your measles vaccine, you can actually in Ontario obtain your immunization record. So there's this thing on my screen here, so it's called the Immunization Connect Ontario. So it's actually an online system where, you know, the vaccines you've gotten from nurses or whoever have been submitted, and usually and this is how you obtain them. Or you can get them mailed to your home. They could be faxed to a provider, and they can even be printed and picked up in Thunder Bay here, because that's where we're located. We're at the Thunder Bay District Health Unit. What I included in this bottom part here, public health locations within Ontario. Literally, Google public health unit locations, and you contact them. You're like, have I been vaccinated against this? Yes, we're gonna send you your yellow card, which is pretty much the summary of all of the vaccines that you've received. And so this is, I feel like it's important to know, were you? Probably. But you wouldn't know unless you access the immunization records, because I don't know, maybe your parents didn't vaccinate you when you were 1 year old. I have no idea. The risk of vaccines, which this is true of every vaccine, not just this one. Why I'm harping on this one is because it's so preventable and it's so infectious and so dangerous. But there's other vaccines that I could harp on, but the risks, because free prior informed consent, you need to know about not just people shoving things down your throat, but what can actually happen. So like any medication, vaccines can cause side effects and reactions. So the most common ones that could happen when you get the MMR vaccine is fever, stiffness, so kind of like, when you have like the flu and you kind of just feel like, oh, everything's achy, a rash, you can get some joint pain, your face or your neck can kind of get swollen because your parotid gland and your lymph nodes, there's like a ton of lymph nodes in this area, right? And we're trying to get an immune response. It's actually a good thing when you kind of feel a little bit yucky after a vaccine, because you're like, oh, great, I got a little bit of the immune response. Like that's actually, people are like, oh, I hate when that happens. I'm like, okay, but like, then you really did build the immunity to it, because you're introducing it in small doses that won't cause illness. But yeah, your face or your neck, if you're gonna get these side effects, they'll usually be a few weeks after a vaccine, which is different than other ones, right? Where it's kind of like the next day you feel yucky. For MMR, this could happen up to 1 to 3 weeks after, and they're normal. They go away within a few days, and you can take medication for pain or fever. So to me, how I think of vaccines, or really any treatment option within healthcare, is what is the risk of harm, and does that outweigh the risk of benefit? Because it is a benefit risk, like, is it worth not getting one vaccine to prevent something that's truly really bad? And sometimes the answer for you might be no, and sometimes the answer for you will be yes. But what I would recommend is that you gather all the information you can from reliable medical sources to actually figure out what it is you think. Because vaccines is it's a hard thing in our community because, for lots of reasons. One, there's been lots of, historically, Canada's healthcare system has experimented on Indigenous people. And so, of course, you're not going to necessarily have trust about someone injecting something to you. There's thoughts about big pharma, and they're just out to get your money. And so there's lots of different theories about vaccines. What I can say as someone who treats patients and sees the positive impacts of vaccines is I don't think they're a part of big pharma. I think they're so crucial. And when I think back to that medicine chest clause, our ancestors who didn't even know, they didn't know measles, mumps, and rubella was coming, but even they knew the importance of we have to have a medicine chest clause. We need medicines that protect us against things that were brought to us. So being allergic to something, so there's a small chance of serious allergic reactions to vaccines called anaphylaxis. It's where your lips get swollen, it's hard to breathe, you get hives, you start to, and when it's more dangerous, you start to blue in the face. So true of any allergy, you eating a peanut or you getting a vaccine, if it's gonna happen, especially for a live vaccine, it's gonna be within the first 15 minutes, majority of the time. Hence why when you get a vaccine and your nurse is or whoever gave you your vaccine is you should sit here for the next 15 minutes. You're no, I want to go. I don't want to sit here anymore. I'm not sitting here. That's why I want you to sit there, is because if you're gonna have anaphylaxis, which can be treated with an EpiPen, there's a healthcare provider right there for you, it's gonna be in those 15 minutes. So do stay for those extra minutes and just do something on your phone. Because they can actually watch for abnormal or those very, very rare reactions, right? And treat them quickly. You at home getting in your car right after the vaccine, and then you're oh, my lips are really swollen. It's just, you might not recognize those things. And so do stay just for a little bit so that we know that you're okay, and didn't develop anaphylaxis. Very unlikely, very difficult, but it is, some people are allergic. So that's all I wanted to talk about in terms of measles, mumps, and rubella. The next part of our talk is going to be more focused on rights and how to navigate healthcare systems that are inherently racist. But this was, I think, just an important tidbit that I want our community members to know and to talk to your relatives about. Like really, I think it's the conversations that we have with each other that prompt action, right? When I talk to my sister or my grandma or my mom, I'm like, hey, this is like, I saw this presentation, this native doctor was talking about this, and you talk to other people, it brings that awareness to something that is quite serious. And like I say, in the 80s, we didn't have measles in Canada, and it's coming back, and we just really want to cut that short. Just wanted to pause. I don't know if we have any questions or anything that have come through.
I haven't seen any yet.
Okay.
I don't know if
There's been a few comments, but not that many questions.
Okay.
One question came a little bit earlier in the chat. It was, why do some have two traditional / spirit names? And this person was gifted another spirit name from an elder.
Yeah, that's a really good question. So the question was, for people who didn't hear, is why do some people have more than one spirit name? Like if you have two, like you were given one and then someone told you one. And I think it's kind of, oftentimes, I'm not sure if this is your situation, but when people have more than one name, I find that it's usually because it came from different nations. Like you were here in your community in Rocky Bay, got your name, that's what people knew you as. You live somewhere else, you're in BC, an Haida elder, which is a completely different First Nation, gave you those names. And so I don't really know like what it is about why people have more than one name. But I do know that those, like it happens and it's totally normal like that. And I think the names that you sort of receive subsequently, like afterwards, are often reflections of where you are in your life path at that time. So, you know, like an elder or something will see something in you, or they're like, this is what you were, and so that might not have been the case when you were first born. And so I think it's an evolution of what your spirit has come to this world to do. And one isn't better than the other, like one's not incorrect, they're both correct. So don't think of it as like, well, whatever my first one was, that was, that, you know, it's what connects to you, but it definitely does occur. And I would really encourage people to connect to both of those things, connect to all of the things, your name, your namesakes, your clan sakes, connect to those things, because that's, I think, for our people, where wellness starts. I think that's where emotional and mental wellness starts. Yeah.
we could show you this one, it's kind of a long statement.
Okay.
Or we could always wait until after the break.
No, I'll just do it.
You can, but have choices, or I'm not sure.
Let's see what we can do here.
Okay.
Fair enough. So we have a comment. So I disagree with some of VC, as I've had 18 family members pass after the booster, middle age with turbo cancer. I also disagree about pharma because many speaking out of them gaining profits, fixing one issue, then causing another issue. Yes, it came from another nation, from Turtle Island, where my grandfather settled in Wisconsin. Bawating, my grandfather was also a signature of the Robinson-Huron Superior Treaty. Yeah, I think that's fair. I don't want to be confrontational. And I think whatever makes sense, how I think of it, even for myself, is like, where did this information come from? So if it's your life experience that you feel that a lot of people passed away after a booster, I think that's just how you see it. And we accept where that is, and we sort of, that's where it is. Oftentimes it's really hard to correlate, I'm just saying generally, within medicine, when there's been an adverse reaction or a death as a result of one thing. It's often not the case. There's often a lot of things that brought people to that situation, and or other things going on. Like, it's really difficult to, if you were to like take one thing out of like what's caused that. But I hear what you're saying, and I respect that that's your opinion. And I think like looking for information and keep educating and figuring out like, yeah, I think that's your life experience, and so that's where things are at. So I appreciate the like an alternative perspective to what I'm saying. I still will have the messaging as an Indigenous physician, born and raised in community, that vaccines are important, and I see the benefits, and that's just sort of, yeah, like how I see things on the other side of the spectrum. And just so everyone's aware, I'm not getting paid to tell you about the MMR vaccine. I kind of wish I was. That would be cool, to get extra money for doing that, but no, I'm not getting paid to do this. I'm just wanting to share this information because I care about our communities, I care about our nations, and I want us to be informed. Yeah, but thank you for sharing that. Anything else?
No other questions have come in.
Okay, so why don't we, oh, sorry, there are vaccines, but they were sent to me. Okay,
Sorry.
I'm gonna go back, it's my fault, okay. What does live vaccine mean? So that means a part of the virus, like a segment of it, is physically within the bottle. That's what's being injected, a modified version of what the virus actually is. So that's what they say when they mean live vaccines. Because we're trying to activate your immune system when we give it. How often do you need to get MMR vaccines? Great question. So when you're age 1 and before you go to kindergarten or school, age 4 to 6. Otherwise, if you're once you've done that, like you chew the vaccines, you're done. You don't have to think about it again. It's not like tetanus where you have to get it every 10 years or your flu shot where you get it every year. It's just like 2 and done. Is measles an autoimmune disease? That's a really interesting question because viruses, kind of, because the purpose of a virus, like if I were to think of just like if I was the virus, if I was the measles virus, the point of what you are trying to do when you're a virus is to recreate yourself. And so you are trying to mess with people's immune system and find ways to work around so that you can create more of yourself, right? That's the life process of a virus. And so I do find that when people have viruses, it is kind of like your body is attacking itself. I don't think it's officially classified as an autoimmune disease, but I think it has autoimmune properties, which is, like trying the virus affecting your immune system and trying to find ways to counteract you, essentially. You're going to do a vaccine, the virus is going to try and find a way that's just the nature of viruses. They're going to try and find a way to like get past that. Will your body / organs recover from measles or sorry, I just have to move this. Or COVID or other diseases. I don't know how to move this. My screen.
Can I go help?
Yeah.
Thank you.
Oh, I got it. Okay. Will your body organs fully recover from measles or COVID or other diseases if someone has lung disease with pulmonary fibrosis? Really good question. Pulmonary fibrosis means that there's scarring of your lungs. And so like right now, if I were to do a chest x-ray, say for example, when I was a kid, I had a really, really bad pneumonia infection. I didn't, but if I did, pulmonary fibrosis is scarring, and scarring can happen for a lot of reasons. Scarring does not eventually recover. You can still keep your lungs healthy and well with like traditional medicines, Western medicines, puffers, all of that. But kind of once scarring is internal, like there's scarring in your lungs, it's very it's likely to always show up and always be there. So you might get an x-ray and it kind of might say the same thing. Oh, there's a little bit of scarring here, especially if you were someone as a kid or even as an adult where you developed a lot of lung infections. There's going to be scarring there, and what that means is that part of the lung has a harder time exchanging oxygen, right, for your breath. And so that means we have to be even more aware and cautious of how to keep our lungs healthy and well. But do you recover usually from measles? Yeah, if you were vaccinated and or you like develop some immunity to it, you would. Most people, it's like getting a cold, right? Most people recover from a cold, most people recover from measles. Not if you're a little baby or a super older adult. That's not true. A lot of people like it's a hard recovery, a recovery that requires a lot of intervention. That's a good question about COVID though. So they're currently in the process of COVID, like, and learning more about long COVID. So that's colloquially known as what are the after effects after you've had a COVID virus? How does it affect you, like 6 months from now, a year from now, 2 years from now? And so the virus has been around long enough that they're starting to pull some of this research together. But again, it's very difficult, right? Because like I said, it's hard to pull one, like, is it really that COVID made you tired, or is it that you were anemic and you had genetic, like, so that's what I mean about how it's hard to tease out what, like, this one thing caused this one thing. It's often a multitude of things, but it is a common phenomenon, at least within medicine, for people to feel like they just never got their energy back after COVID. I don't know why, I don't know if that's true for everyone, and so that's kind of why they're doing research is to study like what's gonna happen, what are the long-term repercussions, because we don't know. Like I know the long-term repercussions, if you got chickenpox, is often people get scarring. Like we know that like if you get really bad chickenpox, there's gonna be a scar. And so that's just not true of COVID because it's so new. So we're trying to learn more about it, but technically at this point, not sure if our bodies fully recover from COVID. I don't know. My community has had a few people with blastomycosis over the last couple of years. Yeah, I have ILD, interstitial lung disease, pulmonary ILD-PF, interstitial lung disease, pulmonary fibrosis, and systemic sclerosis. I live in Alberta but want to go home to Northern Ontario in the summer. What can I do to protect myself? I'm also on oxygen. I will also ask my specialist as well, but just wanted another perspective. So that's a really great point. So blasto is actually quite common in Northern Ontario, especially Kenora area. So that's pretty much like when you're digging up dirt, like you're gardening or your dog is digging a hole, right? And it comes from soil and it embeds within your lungs. So blasto is one of those things that causes lung scarring. So ways to prevent blasto for sure, like to even just for people in Northern Ontario, like when you're digging up ground for a construction project, for your garden, for whatever, wear a mask. That's a big part of it, is wear a mask, because that's how blasto sort of gets in your system is by breathing in, and it's not by touching and then your mouth, it's breathing. But you're right, as someone with systemic sclerosis for people who don't know, is when your blood vessels, they're thick and they're hard. Blood vessels are supposed to be kind of like flexible and move, right? Because blood is coming through. And so you want it to be able to like get smaller, get bigger when you're running or when you're doing an activity. And so sclerosis means it doesn't have that flexibility, right? Which can be like a really concerning thing. So when you come to Northern Ontario in terms of protecting yourself, one, I think, is that it's becoming a normal thing where every summer we get fires, which is awful, and that's actually a direct result of the climate crisis that we're in. But when we do get fires, wear a mask, do not go outside, do not run outside, get air purifiers for your home. Like for me, I have air purifiers in my home, even when we're not in this like fire season or pollen season, because more and more people are developing allergies. Like you might be someone where you're like, I never used to have this allergy before and now I do. And it's because of the degree of pollution, and the degree and how much extra is being released into the air that our bodies are responding to it. So I think that's the biggest thing, air purifier. If you aren't able to afford an air purifier and you have a child in your home, I have successfully gotten Jordan's principal to cover air purifiers, especially when like a kid has asthma, or like in your case, right? Jordan's principal wouldn't necessarily cover that, but if you're covered through status, I would really try and figure out about getting filters for your house, air filters. Because that's a really big thing, is physically reducing the amount of exposure to things that you're having. So that's one good way to protect your lungs. In your case, you may or may not take puffers, but I would stay on top of those. And yeah, just try and avoid things where you're inhaling smoke, which is sometimes difficult because people are like, well, what about when I smudge? What am I about that smoke? I don't know. I don't know if it's a part of it or not. Like in my head, I'm like, okay, it's a traditional medicine in the same way like tobacco, right? Like it's a traditional medicine. It's not inherently harmful in like small amounts and when you're using it for traditional practice. But there is, Carly's just showing me the little bottle. People can get distilled versions or water versions of smudge. So say you're really sensitive to smoke, like when I was smudging and you start coughing and hacking. A way to get around that is if you boil those ingredients or just buy from someone, like there's lots for like people, it's like a thing that you can purchase often. Or you yourself can distill those ingredients when you boil those ingredients and then put it into a bottle. There's your, you get like the same smell, it's the same energy, that's still the same principle. I know for myself, because when I worked in a hospital and it's the most grueling, awful place that I've worked, I would bring my liquid smudge because I'm like, I need to smudge after this. Like this day is done. I'm done with this. But like you're gonna set the fire alarm off, so I would just like spray that. And I went through a lot of bottles. So that's one way. Just avoid things that are gonna irritate your lungs. So just regular sprays of water, like those are way better. Okay. Any other things? Okay, so let's take a 5-minute break because it's already been an hour. So if people can get up, stretch, get some water, we'll be back in 5 minutes and then we'll finish the presentation off. Great. Okay.
Hello, everybody, we're back. Thank you so much for your patience. Before we have Alexa get back into her great presentation, I just wanted to remind everybody about the survey again. Very shortly, we will be posting the link to access the survey. And within there, we really look forward to receiving all that information and everybody's submission. And I want to promise you that I provide every comment, every request for future presentations to Dr. Alexa. And again, another reminder is that this for this presentation and this event today, we do have gifts that we're going to be providing to everybody who submits a survey and who also gives us permission to send them a gift. So by providing their contact information or their address, and there'll be like a part of that within the survey for them to provide us with that info. So thanks so much everyone for attending, and I will get out of the way. Thank you.
Okay, so as requested, so I do want to talk about UNDRIP. It's the United Nations Declarations on the Rights of Indigenous People. Why I want to talk about it is because it's honestly the most comprehensive and I think closest Western documentation that reflects what our Anishinaabe rights are, like our rights as Anishinaabe people. I think there's a lot of overlap. And so this is where the United Nations, all the Indigenous communities from around the world came together and like, okay, what do we have the rights to? So UNDRIP, which is a literal physical document, it's a document, and what it's meant to be is it sets out the rights of Indigenous peoples around the world, not just here in Canada. It includes declarations, conventions, treaties, and the goal of it is to uphold human rights and international law. The thing that's difficult about UNDRIP, because if you read it and you're like, yeah, this is exactly what we need, yeah, like this is, and then unfortunately, many of these rights aren't codified legally. And so what that means is that when things are these are more like authoritative ideas and approaches that the United Nations is giving to countries that they hope can influence laws and practices. And so unfortunately, a lot of these rights aren't codified legally, so it's hard for them to be enforced. Hence why Indigenous rights are often not recognized in Indigenous law, right? Like it's our laws are often not recognized, and then that's a part of it. And so ideally we want to be in situations where these things are legalized, because unfortunately that's the only way to really get people to act. Is it has to be illegal, right? There has to be some legality. There has to be almost like there has to be consequences to you not recognizing my right as an Indigenous person. Otherwise it's in Canada's best interest to not recognize our laws, right? And not recognize our rights. That's within capitalism and Canada's, that's within their best interest to keep our rights not codified legally. Something that I want to talk about, which is really prevalent in our communities and in our healthcare system, is anti-Indigenous racism, which is actually different than racism. Like it's actually a very specific form of treatment. So it's a form of race-based discrimination, stereotyping, discrimination, or injustice that's experienced by Indigenous peoples. And so why it's different than just like, oh, like that's just racism, is because anti-Indigenous racism is predicated and then continued by the incorrect belief, essentially, that Indigenous people, our Native people, our cultures, our knowledge are inferior, right? That like that's what anti-Indigenous racism is. So there's a behavior that someone has towards you. There's actions that healthcare has towards you that you might experience as discrimination or stereotyping, and it starts with the core belief. And it's so ingrained in so many things. Like if you ask someone, hey, do you think Native people are inferior? Like if you asked every healthcare provider that, well, I mean, most would say no. They would say no. But it's unfortunately so enforced and ingrained in our society, right? That even if you explicitly hearing those words, you're like, oh, I don't believe that. That's not me. I would never think that. It's examples are happening all the time, right? Think of all the missing, murdered Indigenous women, Two-Spirit girls, murdered, missing lives, that don't get police reports, that aren't investigated properly. When Barbara, or the woman here in Thunder Bay, she's really, her case was actually quite well known here in Thunder Bay, where she had a hitch that was thrown at her. And it was very clearly like, the person said a really racial native thing and threw this at her, and eventually it was a long course, but she died. And so there's explicit racism and then there's implicit racism. I'm gonna go over what that means. But that's the belief, right? Is like, oh, well, I don't really need to continue investigating you for this issue because you're fine, right? So even though you might not think it, unfortunately, most of our social media, most of our policies, they enforce this idea implicitly, which means like on the down low, like it's infiltrating in all messages that come towards you. And so that's why we always need to think about our implicit and explicit biases. Even me as a native doctor, I have implicit bias, like meaning that I, based on someone's race or their gender or their orientation, even when I try to be the best doctor that I can be, there is implicit bias, and I have to check myself at the door every time. So no one's immune to it. It's not like I'm the most depressed person and therefore I don't have implicit bias. We all do. And we can't help that. It's just, that's the way it is. That's the way our world was designed. But what we do have control over is how we respond to that and how we think about that. When you think about, like, for example, maybe you think about houselessness in your communities, maybe that's something that really affects, your downtown population, is that a lot of people are houseless. And you're like, oh, like, maybe when you drive past, you like lock your doors. And you don't even really realize that there's this like, oh, I locked the doors. Why did I lock the doors? Like, no one's coming towards my car. But these are these little tiny things that contribute to our overall action and what we think of in a society. So anti-Indigenous racism, it emerges from colonialism and the legacy of colonial policies in Canada that still exists today at this very moment. Like I said, implicit bias, this is kind of cut a little bit. Implicit bias, why this is important to know about, and this is something that I tell my other providers, not necessarily like as relevant to people who aren't in healthcare, but Indigenous people are less likely to receive further investigation for any health related issue, right? So like an example of this would be like, oh, I have a headache. You're like, oh, okay, well, like, when did that start? Oh, it's been there for a while, blah, blah, blah. You're having all this information. It's like, oh, okay, yeah, let's take some Tylenol. And it's like, ooh, the implicit bias there was that you assumed that further investigation wasn't needed, right? Because a lot of our people, honestly, they're not the most forthcoming. Like, they're not like, here are all my symptoms A to Z, let me tell you all of the things, right? You need to be able to articulate and ask questions in a way that promotes dialogue. And when someone's speaking, don't interrupt. Let them actually tell you all the things they need to. So you can garner a lot of information from that. Just because someone doesn't self-volunteer that, you still have to rule out red flags. I still need to ask, hey, when you have headaches, does your vision change? When you have headaches, are your hands and your feet going numb, right? There's this, but there's sometimes in medicine an implicit bias of like, oh, this person just has a headache. And that's more likely that like, oh, it's just this, is more likely to happen to Indigenous people. And so it's why I investigate. And it's what I tell my colleagues. They're like, Alexa, you like order a lot of stuff. You, which is like a part of my, yeah. So my colleagues are probably like, yeah, Alexa will investigate you for it. Because we're just, it's more likely, and that's why you hear those stories, right, of like people who were sitting in the emergency department. And I don't necessarily think it's because people are truly being malicious. There are a lot of emerge docs that I work with that are good and they work with their people, and I recognize them as amazing providers. So I don't necessarily think it's malicious, but it comes off that way because the ramifications of just like, oh, you're fine, doing that to Native people is death. That is often the outcome of that, right? Or an increased burden of disease, which is that disease affects you more than like a non-Native person. So because people are less likely to be investigated, less likely, because people might not necessarily be forthcoming, that's why we have like worse outcomes. So we really need to think about implicit bias for you, however that applies to in your life, and especially in healthcare for healthcare providers. If someone's like, oh, I want to do this, sometimes like there's, I'll just speak to a point that like a lot of people have, and they'll come up to me like, oh, I told my doctor I wanted this, this, and this, and they didn't order for me, and they're a terrible doctor. And so I think there's the check your implicit bias at the door. That's what your doctor should be doing. That's, I think, should be a part of their Hippocratic oath. It's not necessarily, but that's what they owe to you, is to check themselves. Am I actually under investigating something because I have implicit ideas that Native people are less than? Or is this actually just like medically not necessary? So I don't necessarily think if someone's like, your doctor's like, I'm not gonna order that MRI, you're like, this is the worst care I've ever received, it can feel that way because our interactions with healthcare are just, they're so negative all the time. So it's actually hard to realize that when a provider is telling you like, hey, like we should probably look at this first, or like not investigating isn't going to change our management, or like it's at times can become hard to navigate that because our defense is on and we just perceive that as like, they don't care about me, they don't care about Native people, and that's what healthcare is like, right? And it's so easy, that like jump, because it happens so often, right? We're trying to change the paradigm. Like here at Onwa, we have amazing nurses, we have amazing people that help navigate the healthcare system. We have Native people in medicine. There's lots of things that are being happened. We're trying to make it better. But it makes sense that that's how you're gonna respond. Also know that like, have that open conversation with your doctor, right? You might think that's something that you're like, I need this, and if I don't get it, and then it's bad. But it might not necessarily be. And I think we have to assume that not all encounters are gonna be bad. I think that's a part of it. They will, like, I say this, but like, I still go to the Emerge, and I like put on not a hoodie and sweaters when I go to the Emerge, even though I'm a doctor, right? Like I try to like look presentable, so that way there's not this first glance implicit bias that happens in my triaging, right? Because I want to be triaged high when I have medically scary issues. I want to be triaged. Like triage is like when you say 1, 2, 3, 4, 5 in terms of how bad is your thing right now. And that's, that's a part of it. So I still show up to the emergency department, and I'm conscious about what I wear and what I show up as, because I don't want to be like the Native bum that like is, I don't know, not dressed nicely and is poor, and like I don't want to perpetuate that stereotype, but hope for the best and act like and manifest that for yourself, that like that your encounters in medicine will be good. And because share from your heart, like share like, this is hard because of, because most times like especially a lot of doctors, like I don't think they're bad people. I think we're just in a system that really does not support people unlearning what we're being indoctrinated with every day, and we need to get through that. And so this is kind of similar to the last point. So Indigenous people in Canada are impacted by high rates of poor health, largely related to racism and ongoing practices of colonization. And so like not just the negative, because there are like, I feel like a lot of how epidemiology, which is the study of disease, is presented to us is like Native people are at risk of this, and it's like all of the like ways that we're at risk, and none of the like, actually we have cultural things that are like protective against this, right? Like the spin is usually like, we're like the #1 people that have it again. So those things can be true, we're moving through those things, but we deserve access to quality care that is culturally safe. I'll talk about what cultural safety means, because there's a definition, and then there's a perception. So first I want to talk about something that I think is good to know about, because say you are being mistreated poorly, like someone said something to you that just like you're like, oh no, you should not have said that. Or you think that the racism or discrimination or stereotyping is affecting your treatment and what the care that you are receiving. I think it's important to know about like procedures, about what do you do about, like, how do you get accountability for that? And I would say that overall, we're not in healthcare, we're not the greatest at responding to complaints and taking that and then readapting. We're starting to get better, but it's still a long ways to go. But usually when you don't like something that's happening in your healthcare, regardless of who it is, your home care worker, your physician, your nurse, the paramedic, right? When you have complaints, usually the first thing that people recommend is like going specifically to that person or to that clinic or to that organization, and trying to resolve it in that sense. That in and of itself is pretty scary for a lot of people, because they're like, I'm not going to confront this person. That's the whole point of cultural safety, right? There's a power differential. I'm me, the doctor. I have like, I'm on this side and you're on this side, and that's unfortunately healthcare creates the hierarchy of like who's most important and who has the most say. It should be the patient, not the physician, but it's in our healthcare at this moment, that's the other way around. But ideally to practice that teaching of courage and bravery. I've been so honored and humbled by patients who told me to my face that like they didn't like something that I did. They didn't like the way I responded to them. They didn't like the way I phrased something. They felt like I was being rude when I did this, right? Like when people give me that information, I mean, we need to train doctors so that they can receive that information and not think, and then become defensive. Well, that's just you, like I want to take criticism, and because I want to be the best doctor that I can be. And I hope that that's true of all of my colleagues, all of the people within medicine. But when you have a complaint, like address it. Like if you feel like you have the words, if you don't, write a letter. Even if that's uncomfortable, bring other people with you, right? Like you yourself don't have to feel like you go into the room and then it's like you against the other person. In hospitals, how it usually works is each hospital has its own like human resources complaint process. And it's really hard to talk specifics about it because it's different at every single hospital, different at every single long-term care home, nursing facility. But just generally, that's the area, like, you have the option to do that, to file a grievance, file a complaint, file a concern. What I think is relevant to me and what I am most familiar with being a physician is the CPSO. So the CPSO, that's the College of Physician Surgeons of Ontario. So that's the body that governs us, because healthcare workers are self-governing. That means that the government technically doesn't really have a say on what happens. So if they're like, we don't want you to do this thing anymore, technically we're unregulated profession, so we're not like, so we can kind of, if anything, it's a lot of power, but it's also very helpful for when policies are trying to create healthcare and make it worse. For example, getting rid of gender affirming care in Alberta, absolute worst, like that's a terrible decision for healthcare, and all doctors know that. But it's not doctors that were making that decision, it was policymakers. And so we can't have that. Like that's just, that puts us back so many steps in medicine. And technically, like I did gender journey, like we had a talk and we're like, what are we gonna do? Like, well, technically my college of CPSO has actually written a statement to the province of Alberta saying that like they really do not agree with this, and technically government cannot force doctors to do the thing. Why that happened is because if you think back to Nazi Holocaust, it was the German government that was like telling doctors, yeah, do these experiments and enforcing them to, right? And so that's where this clause came in, where governments can't do that. Governments can't tell doctors or nurse practitioners or anyone in healthcare what to do. Obviously, there's a charter of rights, right? So we're not like doing crazy things, but it just means that we're gonna do what's right for people and for their health. So if you have a complaint or a concern, so when it gets to the college level, that's like pretty, like that's a high level complaint. So there's sort of kind of a couple of different options. So the reason why you would go to the college, like you literally go CPSO website, You can actually look up any tribunals, or not tribunal, yeah, like court proceedings that are happening for doctors who are undergoing really egregious complaints like sexual assault, like those kinds of, like you can actually see the days that they are scheduled. So it clearly outlines who has a complaint, what the complaint is for, and they get looked over by a group of people, not just doctors, a group of people. And the CPO is in your best interest, right? They care, they actually want to make sure that you are getting good care. And so a complaint or concern, if you think your care provided was poor, inadequate clinical care, for example, you got the wrong diagnosis, or you don't think the care and treatment you received was the right treatment, there was poor professional conduct, someone said something to you, or you're just like, no, like, why did you say that? Of course, this goes without saying, sexual abuse and inappropriate conduct, that includes having relationships. Like, if you can't, like, it's technically a violation of our college for physicians and really anyone in healthcare to have relations with their patients, even if it's outside of that. Like, that's like a pretty hard, don't do that. So yeah, that's when you have a specific complaint, and you can look up any doctor that's in Ontario. We're all listed there, we have to be, that's where our licenses come from. I'm not saying this because I'm like, oh, I want you to go out for your dog, like, and then just to receive a bunch of complaints, but you should just know that those processes exist and that you're not helpless to this. It's like, oh, that's just the way it is. No, we need changes to be made. Like, we have to start reporting these things. And I'm sorry for the times that it was reported and nothing was done about it, because that happens all the time. And then people give up because they're like, what's the point? There is a point. I really do think we need to push this. So any of those things, you would contact the college. If there was something where you're like, your complaint is because of the state of healthcare, for example, oh, I don't have a doctor, or I think my doctor, the wait times are taking too long, that's technically not a complaint that the college would deal with, but it is a complaint that the patient, Bunseman, it's like an organization, and there's actually a phone number. So if you Google this, Ontario, there's a phone number that you can, and you can call and be like, hey, I have this concern. My relative's in a long-term care home. I'm concerned that like they're being left in, like their bed, which is dirty, or their, whatever it is your complaint is. That's where you would make that for long-term care homes, community home care. And sometimes there are actionable things that can come of that. Something you should know as a patient, I'm just gonna fix this screen here. Know your rights. Okay, well, it's cut off, but that's okay. Knowing your rights as a patient provincially. So there's something called Bill 22. So that's an act to promote patients' rights. So there's a bunch of things in this thing, and that, like, there's tons. And so we're not going to go through every single point that's in Bill 22, but it's also known as the Tommy Douglas Act, Bill 22, Patient Bill of Rights. So it's what your rights are as a patient, accessing OHIP benefits within the province of Ontario. So you have the right to give or refuse consent to the provision of healthcare services. So if a provider is saying you need to do this chemotherapy, you have to do this chemotherapy, technically not true. There is nothing in medicine that if you don't consent to, you don't have to do. There's one exception to that, which is related to mental health. I can talk about that. But generally, like, if someone says, oh, no, you have to, no, make an informed decision, talk more, ask about the risk, ask about the benefits, inform yourself, make an informed decision. But just because someone says, oh, you have to do that, doesn't mean nothing in medicine is mandatory, right? Like, they're technically all suggestions. When someone says, I think you should go and do this thing, it's a suggestion. Outside of when you're formed, which is different, that's when you're, like, in mental health, you're at risk of harm to yourself or others, right? Like, you want to kill yourself, you want to kill someone else. Like, when there's like actual harm that's imminent, there is such a thing as being formed, which is where a doctor actually signs and says, like, this person is unfit to make medical decisions. That's a whole separate, like, we could talk about that for hours, and how there's a lot of messed up things that are a part of that and who gets formed, and mental health generally, but just know that that's the only time where like, no, like there's a legal obligation for someone to come pick you up, bring you to the hospital to get assessed by psychiatry. So that's separate though. Any other thing in medicine, it's just choose whether you want to or not. It's not mandatory. You have the right to receive publicly funded healthcare in your home, community, and healthcare facilities. So that's interesting, right? Because for people who live on reserve, do you have access to long-term care homes? Are you able to stay in your community and still, oh, CJ, my computer died. Is it?
It's just like power.
I don't know. I have a
It's like
charger.
we're going to put up the
Yeah,
technical difficulties.
does it have a good range on it?
My computer was fully charged though.
Still showing the bill of rights.
Yeah, I don't think it's my computer. Just waiting to get back on. Sorry folks, technical difficulties.
Does that mean that you?
Okay. And we will go like this. Share my screen. Oh, I need someone to enable screen share.
Yeah, you back in as participant.
Mhm.
Co-host. Yes.
Okay. Screen will stop sharing. Yes. We will do advance. Portion of the screen. Share.
There you go.
I see.
You're back on.
Okay, we can see? Sorry folks, this happened to actually right before the call, we had like things glitching. So maybe it's creator being like, okay, move on, don't talk about this anymore. Yeah, so this is an interesting point about Bill 22, so being able to receive publicly funded healthcare. Because in theory, it is covered, but how many people have access to it is another thing. And that's particularly of concern for people who don't live in urban or even rural settings, right? They live on reserve. That's not technically true. But it is a part of our Bill of Rights. The right to participate in any assessment of personal care requirements and development of plans for care. So that means that when, say for example, you're diagnosed with something, you're diagnosed with eczema, and you're like, you can ask like, hey, how did you come to that conclusion? Like what makes you think that it's eczema? And then, maybe the next step is like, oh, we're gonna do Galaxol base, we're gonna do some steroid cream. And you're like, oh, actually, like I would like to add this. Like there's a medicine that I use, it's called bear grease, and I would like to include that as part of my plan to like help with the eczema. So that's an example of being able to participate in your own care in the care plan. The right to be treated by healthcare professionals with courtesy, respect, dignity that recognizes and reasons to individual needs and preference, including ethnic, spiritual, and cultural factors. So it's not enough when we in healthcare say, oh, we didn't know, or like, sorry, like I I don't know how to accommodate your cultural or like the ethnic or the spiritual things that you want as part of your care. You're right, as a patient, provincially and federally, this is true, is that there has to be an effort made into making those things happen. We want those things. It enhances your care, and for us as physicians or us as healthcare providers, it makes your care better too. Like it's good on both of our parts. So there's shared interest in really trying to incorporate specifically spiritual, ethnic, and cultural factors into your treatment plans and care. I think that makes them more successful. And we want to be able to do that. So there's often a lot of questions that I get from patients. So I don't agree with what my healthcare provider, that's a typo, but said, can I get another opinion? And the answer is yes. So if this is true of anything, if someone ever sort of gives you an opinion, discusses a treatment plan, or like you've seen a specialist or you've seen a doctor and you don't agree with the diagnosis, you are fully within your right to be like, I would like to be referred and to get another opinion. I would like a second opinion. OHIP covers that. Like that's a covered expense and activity that can be done. So yeah, it's totally okay to ask for another opinion, or like, hey, can someone else like review my chart and give some perspective, right? Like those things happen all the time. And I think they're an important part of quality management, actually, is when other doctors look at other people's things and then we say, oh, like this is how I would do it, right? Every single provider does everything different. Nobody is like the same. But you're always within your right to be like, hey, I want to get another opinion. What about my healthcare provider said I should take this medication. Do I have to? No. Everything within healthcare is based off of your consent. So you can choose to or not choose to. There's nothing that is mandatory outside of the Mental Health Act. Culturally safe care, because I think this is what we need. And I say this here, it's not the ceiling, it's the floor. Meaning that's not what we should be aiming to have. We should just have that. Like that should just be baseline. Culturally safe care is the standard we should all be up to at this point. It's just like we want to be more exceptional than culturally safe care, and we're not, and we're trying to be, but we really need to. And so cultural safety, actually, that was a term that was first coined. I think it was by a nurse in Aotearoa or New Zealand, and it was like seeing like, hey, why are like Native people, our Indigenous people, why are they having poor health outcomes? And it was related to culturally safe care, because when you have culturally safe care, first of all, I can't say that I'm giving you culturally safe care. You have to tell me that I'm giving you culturally safe care. So I could be like, I'm doing all of the best things, I'm the most culturally safe doctor in the world. But if you as a patient don't feel that, then I'm not. That's like actually how it's measured. But it's about recognizing power dynamics, because in Western healthcare systems, when we discuss issues, it's kind of like there's like, I'm over here, I'm the doctor, I have all the information, I have the knowledge, and you are over there, you don't have that information, you are just an empty vessel, and I am going to tell you because I know better, right? Unfortunately, that is sort of the attitude that I think that's ingrained in medical training, is the like, I'm the person who has all the information, versus I have all the information because I went to school for like a really long time, but I'm going to communicate it to you so that we can both have the same information. Like I want you to have the info that's not just in my brain. I'm going to say the things out loud so that you can hear all of the information too, because it's not realistic to expect that everyone's gone to medical school and therefore they're going to help, like they're going to know all of this. And I think a lot of people Google things and WebMD things, and I think there's merit to some of that, because I think it helps people stay informed. I do also think it can sometimes be a detriment because people get into the rabbit hole of like, and now I have cancer, or like they're Googling symptoms, and it's the internet is a robot, like it's not a human. And a part of becoming a provider is developing a differential diagnosis, which is like, I don't think it's this because of this. It is this probably because of this. So it's like a mental analysis. So I think it's good to like be informed about your topic, not to the point though, if you're so anxious about it. Like if you're so anxious about it, stop doing it. Like you're probably, and they're like, oh, it's cancer. It might be, but like just do it in moderation, because I think patients who overly focus on like this and this is like, they first of all aren't like received very well in healthcare, which is really unfortunate. Because in my head I'm like, this is a really informed patient, this is excellent. When people know more about their diagnoses than me, I'm like, this is fabulous, like way less explaining for me to do. So I'm like, good, you're like this. So it's something in medicine that we should appreciate, but like to a degree. Just so keep that in mind for your doctor and nurse practitioner friends that you visit, as like, don't WebMD things and then like be set on like something bad is happening. But do be informed. So recognizing that power dynamics exist, let's share the information, build trust and decision making, right? Like, so you have this condition and here are X, Y, and Z options. You can have one of those things, you can have two of those things, you can have all of those things. We can start thing 1 first, 3 weeks later, start thing 2 next. Like there's just so much variety. And so if you feel like your healthcare provider isn't really sharing in the decision making, or they're not sharing their thought process out loud, because it's totally a fault of doctors that we just get stuck in our head. We're like, oh, we know the thing, we know the thing. Like, so sometimes we're not necessarily articulating why we think something, because we're just like doing it in our brain, right? But we have to be able to say it out loud. And so it's totally okay to prompt your provider to say like, hey, like what makes you think that? Like, or like what helped you came to the conclusion? Like, I wonder about this other thing. Do you think that that's a possibility? Like just asking things in really like non-confrontational ways. Explain to me why you think the way you think, or what it is you're thinking. That's a part of culturally safe care. Feeling like you're able to do that, and for your healthcare provider to know that those power differentials exist in the room and we need to shift the power. It has to be where patients are making the decisions and we are helping guide their care, because we did all this crap load of training and so now we know how to navigate the thing, so it's good. We want to work in tandem together, and also recognize, so that's not really on you to make doctors more culturally safe. It's on me and it's on our education systems to make it better. So if that is like, you know, you're into that, you are into like training and educating medical practitioners, healthcare, you know, you're doing those things, amazing. But also, you don't have to. But just remember that you yourself, culturally safe care is the floor. It's not the ceiling. It's not the like be all end all. We should be better than culturally safe care. A lot of health issues, they stem from socioeconomic issues, like related to money, status, gender, orientation. And so so culturally safe care is thinking of treatments, not just in the like, what drug can I prescribe you? Because it's not about like, unfortunately, I'm very well trained at giving people medications because I learn about pharmacology. So it's, you know, a part of my toolbox. It's not the only tool I have. A lot of medical issues are like, because you can't do the thing, because there's no money for it, or because, you know, like whatever it is, the reason that things are difficult in your life. So we need to be thinking about the root cause. So if your sugars are always high and you're someone that accesses a food bank, therefore you're accessing easily refined carbs and, you know, like whatever is cheapest, right? The diabetes was there. Depends how you got it or what kind of diabetes you have, but what's making it worse and what's causing your eyes to be bad and your feet to be bad, the underlying cause is not being able to have healthy food. And so the root cause of that is actually working with social workers and doing advocacy so that people can have access to those things. That's a medical treatment. That is a part of like the medical treatment that we need to be thinking about. What is truly the root of this? Because otherwise it's just going to keep happening, right? Like I can give you all the insulin in the world for your diabetes, but if like the root of it is that you do not have food security, we need to address your food security. Like we need to figure it out. And there's lots of ways that can be done. The other thing is communicating respect for patient beliefs, behaviors, and values. I mean, I feel like that goes without saying, but that is a part of the definition for culturally safe care. So I actually I'm like, we're gonna practice saying these things. Maybe you feel super great when you're like in an encounter with a healthcare provider, like you feel so empowered and you're like ready to like ask the questions and be, you know, like super on top of it. Maybe you're not. So we're actually gonna physically practice saying these things out loud, because this is how we make healthcare better. Patients need to demand better and doctors need to expect better of themselves. We need to always be learning. So get comfortable saying the statements. Can you help me understand? I don't know what you mean, right? And if it's like they're saying the same thing over again, can you explain this in a different way? Because doctors do know how to do that. They just need to be prompted. They just assume if you're not saying anything that you got it. You're like, oh, okay. They have no questions. They didn't say anything, right? So that must mean they probably got it. No, that's not true. Most of the time, Native people specifically don't speak up because they don't know what's going on. And then I get patients like who've had their consult or their specialist appointment. They're like, this specialist told me this, but I don't know what they said. Can we spend the appointment translating what exactly was talked about? And so that's not good management on healthcare, on our part, on healthcare's part. We need to get better at that. But ask the question, say it out loud. Can you help me understand? I don't know what you mean. Can you explain this in a different way? Are there other treatment options, right? Because I don't know, like you might not necessarily be getting all the possible treatment options, especially if there's implicit bias, right? Like I say, I don't think doctors are truly malicious. A lot of reasons that people go into medicine is because they're very altruistic, right? They want to help others. If you didn't, I don't know, you could have been richer doing something way less with way less schooling. So most doctors, like they do inherently care about people. Not true of everybody, but that, I don't know, why else would you choose this profession? Because it's not really a great moneymaker, I'll just tell you that now. Are there other treatment options? Can I get another opinion about this? Right, and or if someone's like, oh, sorry, I'm not gonna order that, and it's like, okay, no problem, can you document that in my chart? Can you please state that you did not order X, Y, and Z because of this? And if it's, and so what that does is it prompts it's kind of like the way doctors think, or nurse practitioners, how providers think. It's like, oh, well, that is technically a possibility. Maybe we should think about that, right? That's how we help with the implicit bias of like, oh no, I'm not gonna do that. I'm not gonna investigate this further. So, oh, okay, like, do you mind like documenting the reason why you're not gonna investigate further? And that helps with medical legal purposes. And also, what does this medication do? I don't know how many times I have so many patients come in and they're like, I'm on this pill and it's yellow. I'm like, no, I don't know what you're talking about. Most practitioners don't know your medication based off the color, like, because there's all kinds of colors and shapes. There's like general ones where I'm like, that's probably what it is, but we don't. And so it's important to know, like, we're like, why are you taking this medication? And you say, I don't know. No, we need to know. We need to be informed, free, prior, informed consent about our bodies. Ask why you're on this medication. Ask. And if you're like, oh, I'm on that, that's not an issue for me anymore. Oh, I don't want to treat that anymore. I don't want to do that anymore. That's fine. Then you deprescribe it. But you need to know, be informed about your health. What conditions do you have? Write them down, right? Like when you go to the Emerge and they're like, oh, I had this thing back when then, and then you don't know what, like you're like, you forget, right? Write your conditions down, write your medications down, have that with you, because that articulates really well in our Western medical system what people need to know in terms of the background, right? Like crucial things. So we really want to know those things and just have that, like something that sits in your wallet. Like, just, why are you on a medication? Know what you're on. Again, reiterate what you think your provider told you. So say at the end of the encounter, you're at your long-term care home and the nurse like did their assessment and they're like, okay, your relative's gotta stay with us because they have a fall risk because they're osteoporotic and their hip is gonna break if they walk. I don't know, just some random example. So what you would do in that situation if you didn't understand is, what I'm hearing you say is that there are concerns for a fall risk and that's why my mom should stay, or that's why my mom should continue physiotherapy and strengthening. Is that correct? Because then you come to a shared understanding, right? Because there's not really a mechanism for knowledge transference that's given and then how it lands on you. Some people hear what they're saying and then I'm like, oh, okay, so like, can you tell me what you heard or like repeat back? And then they'll say something, I'm like, no, we need to, we're like, no, that's not how I wanted it to land, or like that information. So you can come to shared understanding if you ask providers, tell them what you think they just said. Do it. And that'll prompt doctors and providers to give you better answers because they're like, oh no, that's not at all what I wanted to say. So I'm gonna like say it in a better way, a more concise way, a way that's more understandable to you. We're getting to the end, we're almost done. But I do want to talk about the TRC, Truth and Reconciliation calls to action. Because a lot of this, and this is what a lot of Native people in medicine, outside of medicine, allies are really trying to work on, is how to make that better, because there's 3 calls to action specifically that need to be addressed that you know we're given. So one is cultural competency training for all healthcare professionals. You'd be surprised, not all medical schools have that, or if they do, it's like a one-off thing. So we're trying to make that better in schools so that the doctors that are being, you know, turned, like they're coming out of medical school and residency, they have that basic understanding to begin with. Medical education must include Indigenous history and rights, residential schools, and treaties. Like, we need a baseline understanding of those things. I don't think knowing those things makes you necessarily a safe provider for Native people, but it does give you a premise to start with. If you understand, like, why is this the way it is, and then you know the root cause. And then health professionals must be capable of referral to Indigenous specific services when requested. So when it's like, hey, I want to see like a traditional elder, I want to see someone else for this, I want to see to be able to do that. I screenshotted this photo. It has like 2 of the nurses. Oh no, you're not in here. Why are you not in there? I just took a screenshot of this. This is from the She Is Wise magazine, and which is the Ottawa Ontario Native Women's Association. They have a magazine that comes out, and so I really appreciated this one because this is a picture of the nurses that work in our organization. It's called A Changing Healthcare System, and it was essentially, so for people who don't know, Des Moines Health Clinic was created in response to COVID. Right, like our people were not getting the COVID vaccine. We were being higher affected by COVID for lots of different reasons. Like, especially as Native women, that was a key issue, right? Is like, we're not getting the vaccines. Being stuck inside sometimes means that we're like around toxic people or abusive people, and now we're stuck in a situation. There were all of these things that were making it harder for Indigenous women to access care. And so a part of this initiative was how to indigenize, like, and make things so that when we show up to a space, our automatic reaction is to have relief, to go, this is better, like, you know, versus arriving in your healthcare setting and embracing yourself, feeling tense, feeling scared, right? We want our people, Indigenous people, creating systems that are meant for us, programs that are meant for us, buy-in for us. So that way when we step through the door, there's a breath of relief, not an automatic sort of like hunching and feeling nervous and scared. We want that. Because that's how we share information. That's how we give information. I think, you know, encourage, if you take anything from the talk, I think it's to know that you do have rights as a patient. Anti-Indigenous racism does exist within healthcare. You know that, I know that, we see it all the time. Not all of Canada sees that. So we need to be advocates for ourselves. We need to know what our rights are. We need to know what the rights individually for our health, for the planet, all of the resources that I gave you are examples of that. But hold true to those things and know that there are inherent rights that you have, and you should expect and demand better and expect and demand more, because that's what we should be having. Encourage your family and friends and coworkers to ask questions about their health. Like sometimes we come to conclusions about health based off of like anecdotal information, which I think that is like a very common thing, you know, like, oh, I heard my cousin did this thing and they got this thing, and you know, so there's a lot of like what has occurred in your family. But I think ask questions about your health, ask questions from resources that are trusted. Practice your traditional ways of being, whatever that is for you. Even if you don't really practice traditional ways, spirituality as part of your health is important, and when we address those things, your treatment will become more comprehensive. Honor yourself in safe health practices and educate yourself regarding health issues in your area. So what we talked about today was measles, because it's starting to come back. It was eradicated and it's starting to come back, and we need people to be getting the vaccines, especially for our Abenongi or our babies in our community and our elders who have weaker immune systems. It's highly contagious. We need to get on top of this before it becomes a really big issue and fully comes back. So that was everything that I had. Miigwech, everyone. Thank you so much for giving me 2 hours of your time to talk with you. We'll just check and see if there's any questions or comments so that I can address those now.
There's a few comments, so we've got,
Can you just read them?
spiritually and traditional dance drumming is excellent source of healing. There's a couple of technical difficulties. We've got, we deserve access to care regardless of race, color, or creed.
Yep.
We've got one that was commenting back when we were talking about the medical profession and care from practitioners. We have many good medical care practitioners and teams, but some seem to be less caring and more monetary politically, sadly. I admire those who act with humility and compassion.
You're right.
And we have several thank yous that are pouring in now,
Okay.
from Diane and Patty and Jenna.
Great. Okay, so if there's no questions or concerns, I'll pass it over.
Just gonna sneak in here, sorry if you can hear the chair. Miigwech, Alexa, for coming in today on this beautiful sunny day and sharing your teachings with everyone. And thank you to everyone on the call for learning about how you can advocate for yourself and for others. So it's so important to know that, and to know basically everything that you talked about today, and just to recognize that you are the expert of your own body, and that you matter. And so Miigwech so much. Just a few notes here. Our next health talk with Alexa will be Tuesday, May 7th. Please stay tuned for the topic of that event, and just keep checking back on our social media for the topic of that. It'll be out soon. And then just a reminder also about our survey that is in the chat. We do appreciate when we get those filled out and sent in, and just as a thank you, we're gonna be sending out a wellness bundle for those who do complete those. And then also we did talk about the Minimway Health Clinic here in Thunder Bay if you're in this area. If you do have any questions or need help accessing or navigating the healthcare system, please feel free to reach out to us as well. So that's all I have. Miigwech, everyone.
Awesome.
Have a great rest of your day and new start to the week.
Thank you.
Thank you, bye.